Thank you for inviting me. Basal thumb arthritis is something I've been interested in since I started as a consultant, actually. And it's unbelievably common. But what you've got to remember is most basal thumb arthritis is essentially painless. It's a radiological phenomenon and is never seen by a family doctor. If seen by a family doctor, it's hardly ever referred to secondary care, or if seen by a rheumatologist, or it's hardly ever referred to a hand surgeon. And what you and I see is basically the tip of the iceberg, and probably far less of this iceberg there than I'm showing you there. I know Helen McKenna talked to you about conservative management last week, but I've never forgiven her for leaving Nottingham, so I'm just going to have a brief word on it. You can use painkillers, but the trouble is if the pain's intermittent, the pain's gone before you take the tablet. You can use splints. But what I really wanted to stress, and I'm sure Helen did as well, is reassurance, I think, is the most powerful form of conservative management. Explaining to them that the indication for surgery is that they think their pain is intolerable. It doesn't matter what the X-ray looks like, however advanced the arthritis. Surgery can be, some form of surgery can be done at any stage in the future if the pain gets intolerable. So you shouldn't have surgery because of what may happen in the future. You should have it because what your thumb feels like now. And it's up for the patient to decide if and when to have surgery. And I see a lot of people give them that advice and they disappear. Some come back after 3 months, some after 5 years, and some are never seen again. And I think that's a very powerful thing which surgeons shouldn't forget, to explain to the patient something can always be done and it's in their hands when they have it done. And when doing that, you've got to give them the information that the surgery isn't just a walk in the park necessarily. The indications for operative treatment: intolerable pain despite non-operative measures, with a clear understanding and acceptance of the risks of surgery making you worse. All surgery can make you worse, and the limitations. I don't think anything so far really gives you an absolutely normal thumb. I don't believe there are any other indications. I don't believe you should do it because of stiffness of the thumb base or anything else. When I started, there were a whole host of operations advocated and performed to a fair degree around the UK, and I'm sure elsewhere in the world. But basically, they were osteotomies, arthroplasties, trapeziectomy of some form, and arthrodesis. But I think that's really honed down now, and the big three, which are still being considered, are arthrodesis, Trapezium metacarpal arthroplasty, which can be a hemiarthroplasty or a total arthroplasty, and some form of trapeziectomy. And those are what I'm going to talk about today and give you my personal views, which may not be right and may go out of date. It's important to ensure the state of the scaphotrapezial joint under the trapezio metacarpal before doing anything. If you fuse the trapezio metacarpal joint, you put increased demands on the scaphotrapezial joint, such that if it was painful before, it's quite possible it may get more painful afterwards. And the same is also to some extent true for trapezio metacarpal arthroplasty, where you keep the scaphoid. If much of your pain is coming from the scaphotrapezial joint beforehand, your arthroplasty isn't going to get rid of that. Whereas with the trapeziectomy, it doesn't matter whether scaphotrapezial joint arthritis as well as trapezio metacarpal you get rid of. By taking out the trapezium, you basically get rid of it from pain from both. You can tell clinically if the scaphotrapezial joint or the trapezio metacarpal joint is osteoarthritic by first of all knowing that for trapezio metacarpal joint arthritis, there is tenderness over the trapezio metacarpal joint at the base of the thumb, which I know is only a centimeter away from the scaphotrapezial joint, but you can locate it well, and the osteophytes of that joint are usually tender. And you get pain on stressing and moving the thumb joint. In contrast, the scaphotrapezial joint is really a part of the wrist joint. And in that, you tend to get tenderness more proximally or on the palmar surface of the wrist over the scaphotrapezial joint palmally. And you get pain on wrist movement. And I always test people by going into ulnar and radial deviation to see if that hurts. And if it does, they've got, in my view, clinical symptomatic scaphotrapezial joint arthritis. Though it has to be said, the scaphotrapezial joint does allow some movement at the base of the thumb as well as the wrist, and it's variable from patient to patient. So what should you do for trapeziometacarpal joint arthritis? Last time I added up, there were over 159 published reports of surgical treatments in the big journals, Journal of Hand Surgery American and European. And the vast majority produced excellent results for their procedure. They were mainly single surgeon or single center case series and were mainly retrospective. But reading the literature, you could justify treatment, any treatment. And I can remember having described an operation where you swapped around the positions of the trapezoid and the trapezium. You sort of rotated it 180 degrees. With excellent results, but it did seem rather an event for the patient, I suspect. So of the big three, what about them? Well, trapeziometacarpal joint arthrodesis. Typically, it's been reserved for the young manual worker to whom strength is more important than mobility of the thumb. They want a strong thumb to pinch against, which is painless. You can only do it really safely in isolated trapeziometacarpal joint arthritis. So if the scaphotrapezial joint is affected, you shouldn't do it. Basically, the scaphotrapezial joint is, I suppose, affected in about 10% of people I see. Numerous techniques have been described for it, and I've done them all in my time. K-wiring, the disadvantage of K-wiring like that is you have to immobilize them in plaster. And if when you remove the K-wires, if it hasn't united, it's not going to unite. So you have to keep the K-wires in until you're absolutely certain that the fusion has fused. And then that usually means keeping them in plaster all that time. You can use plates, as here. I found they tend to irritate, but that may be just because I don't put them in flush enough and often have to be, but mine often have to be removed. So I went off that. And I've favored in the past fusion with 2 K-wires and a cerclage, figure of 8 cerclage wire, burying this end, which I haven't done here, then the twisted end, so as otherwise that will just irritate the skin. The K-wires can be removed, but I think the tension wire band holds it firmly. But again, they're in plaster for a while, but that's my favored technique at the moment. And then the wires are removed percutaneously, leaving that, but do bury the K-wire. I tend now bury it in bone. I drill a hole in the thumb metacarpal and push it in so it can't irritate, supposedly. The results of it, it's not always easy to get it to unite. And 10–12% non-union rates, I think, are pretty standard. This is a pretty ancient study now, but recorded about 50% complaining of no pain, but 10% still in significant pain. They recorded pinch strength didn't return to the strength of the other side. It was down about 20%. And there was a lack of dexterity, fine dexterity often. Now, with the fusion of the trapeziometacarpal joint, I think patients usually using their MCP and IP joint can still pinch the thumb just to the side of the ring finger, but not beyond. But some people have a very mobile scaphotrapezial joint and can move further. Some it's stiffer and they can't move that far. The absolute success is that you get a patient you've done an arthrodesis on with K-wires, you've removed them, and they come back and say it's great and it's no pain. And then they say, I thought you told me it wouldn't be moving, but look, it is still moving. And they have developed a painless non-union, which unintentionally is a good result. And I wouldn't advise trying to do it, but it does occur sometimes. Not all non-unions of this fusions are painful. Most are, but some aren't. The goals, well, the first operation which really caught on for basal thumb arthritis, apart from arthrodesis, was simple trapeziectomy. It was devised in 1948 by a surgeon called Gervis, who I think worked in Brighton or Bournemouth. He was down on the south coast. And basically, he just took out the trapezium, threw it away, and let the scaphoid articulate with the base of the thumb metacarpal. He reported in about 15 cases good pain relief, restoration of function, and it allowed milkmaids to resume milking in the fields. It's very quaint, very British. And the ironical thing is he got pain at the base of the thumb after he'd retired, and he had the operation done on himself. And he reported the thumb was never as strong as before, but it didn't hurt. And he, in his case report of himself in the Journal of Bone and Joint Surgery, said it was a good operation, it had worked well for him. But what else could he say? The way I do it is through a dorsal radial incision, careful of the superficial branches of the radial nerve, which are all over there. Having exposed the capsule, I incise the capsule longitudinally and raise a dorsal flap and a palmar flap, including the periosteum of the trapezium. If you've got a lot of osteophytes, it's quite difficult. If there are no osteophytes, it's easy. And then I just put in a McDonald or equivalent Watson chain here on either side of the trapezium. So this is in the scaphotrapezial joint. This is in the trapeziometacarpal joint. When you're starting doing this, make sure that you're exposing the trapezium and excising the trapezium. It may sound mad, but people do excise the scaphoid by mistake. And it has happened in many centers, well, in several centres around the UK, which I've seen cases for negligence reports. And it has been done once in Nottingham as well by a very good trainee by accident. But the trapezium has no articular surface, whereas the scaphoid has plenty of articular surface. So if you find yourself looking at cartilage on the radial side of the wrist, you're not on the trapezium. Having exposed it, I get an osteotome and basically split the trapezium into three with a small dorsal part and a small palmar part. And then you got a big central part with no ligamentous attachments, which is easy to remove. And then you can pull the dorsal and the palmar segments one at a time into the center and using a knife, cut around the bone to free them of soft tissues, taking care not to divide the flexor carpi radialis, particularly if you want to use it later. It does happen though. I remove it in bits. I don't try and remove it all as one. I tried to in the past, but it seems an awful lot of fiddle, and this is an awful lot easier, and you don't have a knife flashing into depths quite so much. So that's what a trapeziectomy is. And it fell out of favor because it was sort of a protracted recovery. It shortens the thumb, there's no doubt about that. And biomechanical studies on cadavers demonstrated that will inevitably cause weakness of your thumb, but whether it happens in clinical practice might be different. There's also concerns about osteoarthritis, at this pseudarthritis between the scaphoid and the trapezium, and whether it might sublux as you've nothing holding it in place. There's no doubt, as shown here, you can get osteoarthritis as a pseudarthrosis. This case turned up having had their surgery done 30 years ago before I did any of my studies, and it had taken 30 years to develop pain. The first patients I recruited into my study were in 1992, which is nigh on 30 years ago. And none of them have come back complaining of pain at the base of the thumb. None of my patients that I'm aware of, they've either died or they've gone to seek help from Derby, but I haven't seen any of them. And I don't think it's common. You can get an unstable pseudarthrosis, so it subluxes radially, causing an adduction deformity of the base of the thumb metacarpal. And that is awkward. And I've seen it once again. It's not one of my cases. I don't believe I've ever had this in one of mine. It's often associated with a hyperextension deformity of the MCP joint, and it is incredibly difficult to treat. But because of all these concerns about simple trapeziectomy, modifications came in, and by far the most popular one, particularly in the USA, is the Burton and Pellegrini ligament trapeziectomy with ligament reconstruction and tendon interposition, where you take, and originally it was 50% of the flexor carpi radialis is harvested as a long piece of tendon, preserving its base on the index metacarpal. It's passed through a drill hole in the base of the thumb and pulled tight, so it acts as a sling to stop the thumb metacarpal collapsing on the scaphoid, sutured there, and anything left is rolled into what's called an anchovy and pushed in and put in the void to hold to act as padding and a shock absorber. And they reported a retrospective series, I think it was about 30, with satisfactory results, and they thought it was better than simple trapeziectomy, though there was no comparative study. Other variations to preserve the length and stop and stabilize the articulation from subluxation or migrating onto the distal pole of the scaphoid is the Weilby procedure, very popular in Sweden, where half of flexor carpi radialis is wrapped around abductor pollicis longus, the intact half of flexor carpi radialis and back again to produce a sling. And good results have been achieved from that. So these things have been done, but do any of them really improve the outcome of simple trapeziectomy? Their theoretical benefits and the clinical benefits seem generally were basically in the 1990s generally accepted, but never proven. And so I set off in two studies comparing trapeziectomy alone, the Gervis way, with the trapeziectomy and the Burton Pellegrini ligament reconstruction as they described it. I'm only going to talk about the second one. The findings of both are the same. The only difference between the two really was that there was a third group in the first study, which we can forget about. And in the first study, I put a K-WAR through all the trapeziectomies alone, like this purple one here, to stabilize it during the healing process, because I thought that was more comparable with a trapeziectomy and LRTI to see if the ligament reconstruction bit actually helped. But this was a la Gervis, how he did it. And we randomized men and women to that during the time period, the randomization, did additional procedures like carpal tunnel, which is commonly occurs in conjunction with basal thumb arthritis at the same time, and recovered them afterwards as described originally, which was a crepe bandage for 3 weeks following simple trapeziectomy, but 6 weeks in plaster, with 4 weeks for the KWAR in place for the Burton Pellegrini ligament reconstruction. And then we mobilized with physiotherapy if necessary. Just this shows how I immobilize them, and I'm absolutely obsessive, and I don't know if it matters, but I am obsessive in making sure the thumb is abducted, and be particularly careful if there's a hyperextension deformity at the MCP joint, that the thumb base, the base of the trapezium and the trapezial and the thumb metacarpal are abducted, and that this position isn't adopted just by hyperextension of the MCP joint. So we assessed them 3 months, 1 year, 5 years, and we had a pretty good follow-up with virtually 99% at 1 year and most of them at 5 years. What did we find? Well, we looked at everything with some out-of-date assessments, subjective ones, but the PEM score and the DASH. I'll just tell you, I cannot believe anybody can accurately measure movement at the base of the thumb. It's to a degree or two, as is reported in some of the literature. I think it's very difficult to measure because you don't know really where the fulcrum is and which to measure the angle from. So we found no significant difference in anything we looked at. To give an example, here's the PEM scores. Start high and then drift down. And they drifted down in both groups. They didn't go to naught, but you got to remember many of these patients had other reasons for pain in the hand, not just the thumb. But I'd be lying if I said all of the patients got good pain relief. About 8 out of 10, in my view, are totally delighted. 15% are better, but not okay, and 5% are outright failures. The dash was much the same, reducing, but not going, these are the mean values, but not going right down to 0. But again, these patients often have other comorbidities. And whether the increased dash is still at the 5 years is due to the base of the thumb, the procedure, the trapeziectomy, or other factors is uncertain. We also measured everything we could, including range of movement, which I told you I don't really think much of, grip strength, and thumb key and tip pinch strength, which often people think would be the thing which would be a difference between a simple trapeziectomy and a trapeziectomy with ligament reconstruction. And what we found for all the objective things was no significant difference. Just to show you what happens in our study, key pinch strength preoperatively dropped at 3 months, didn't look so good, and then picked up by 1 year. So it was a bit stronger than beforehand, but really hardly, not significantly, hardly. And at by 5 years, it had dwindled. And I don't think that's a failure of either procedure. I think it's called just getting older. So the conclusion of that was that really trapeziectomy with no KWAR, trapeziectomy with LRTI and KWAR, is that we could find no difference in terms of pain and function up to 5 years, and also no difference in pinch strength. But then the question raises, will there be a longer term difference? Now, I suppose I could have followed them up for longer, but I think I've left it too late now, as many of them will have died. But we didn't see patients coming back with failed trapeziectomies and saying that it was fine to begin with, but it started to hurt and cause problems later. If it wasn't going to work, it seemed not to work with it. It never seemed to work, so that they never were happy afterwards, which happens sometimes. But if it seemed to work in the short term, it seemed to go on forever, though I have shown you a case of arthritis, painful arthritis developing at the pseudarthosis with a simple trapeziectomy, but not one of mine in these studies. So I think that in the long term, if you live 30 years after your trapeziectomy, you may get problems. But does that matter? And would they be got rid of by doing a ligament reconstruction, or will that have stretched out? I don't know. For the trainees, I think the most important thing about advising any surgery for base of thumb is informed consent, so that the patient can make the decision themselves as to whether they feel their pain is bad enough to undergo the surgery. It's very painful during the first week. It's a painful operation. They should be aware of that and stock up with painkillers and take them home even if they don't need them. So at 2 in the morning, when the block wears off, they've got something to take. It takes 3 months on average to make a good recovery from it. Some people are quicker, some are slower, but 3 months on average. So it's not a quick fix. Of 6, well, some of that time you'll be plastered up if you have an LRTI or in some form of bandage or splint. I think 8 times out of 10 it works well with good pain relief. Your thumb mobility should be retained rather than regained, retained. And you should be able to knit and sew, which is a question I'm often asked. And the thumb should be fairly dexterous and move well. I tell patients the thumb the thumb strength will be unchanged compared to before the surgery, but there'll no bit longer be any sudden sharp pains, and your strength will be pretty good, but you'll probably notice it more than you did, that it's weak more than you did before, because you haven't got sharp pains inhibiting you. So some patients do complain that it feels weak. And screw tops, jars, new jars of beetroot will probably remain impossible. So you need an aide or a husband or a wife for that. And I also say many return to work, but I don't guarantee it. I've had some bricklayers return to work. I've had some other people not return to work with jobs where you might expect them. So I don't guarantee return to work, and I wouldn't sell the operation as a way of guaranteeing that you could continue working until the age you wished. You'd say you'd hope it would, but you cannot guarantee it. And it much obviously depends on what they do. And I mean, I was very cautious with the bricklayer. I told him I didn't think he would go back to work. That probably stirred him up to get back to work. I don't know. And 5%, 1 in 20, roughly, in my view, are an outright failure. And if the surgery fails, I think salvage of it is very difficult. I don't, even with a trapeziectomy, converting it to a trapeziectomy with LRTI doesn't, in my hands, always work. And failed trapeziectomies with LRTI, it's very difficult to know what to do next. And some patients end up in, there are reports of other patients elsewhere ending up with multiple operations and not really being improved. Salvage operations and not being improved. So to come on to the next thing, the total arthroplasty. There are hemiarthroplasties as well, but numerous have been introduced over the past 30 years. And as far as I can see, numerous have been withdrawn over the last 30 years, predominantly due to loosening of the trapezial component or dislocation. I went to a BSSH combined meeting with the Spanish Hand Society in Valladolid, I think I've said that right, about 20 years ago. And I was in a panel presenting the results of trapeziectomy while 4 or 5 Spanish surgeons presented the results of different trapezio metacarpal total arthroplasties, all with good results. As far as I can see, all those 5 arthroplasties are now withdrawn from the market and none are still available, but the trapeziectomies carried on. And there's always a new one, and the latest one is always claimed to solve the problems previously encountered with the other ones. And obviously that one day will be the case, but so far I'm not certain that that has happened. This is a Della Caffiniere, which was quite popular in the 1990s. And here's a resurfacing one, which is an alternative to looking like a mini hip replacement. Now, it's quite interesting. I mean, how do you evaluate the results of these new arthroplasties and monitor them? And the Norwegians have formed an arthroplasty registrar where all trapezio metacarpal arthroplasties are recorded or supposedly recorded. I don't know if every surgeon in Norway signs up to it. It only measures one thing, which is how long the implant remains in the body. It tells you nothing about whether they're providing good function or pain relief or anything, but it tells you how many are having to be revised. And they had, when they published, they had 515 implants registered over 17 years, which is about 28-ish a year, which may be a small number for a population of 5 million, I'm not sure. Interestingly, the Swanson hemi-excision arthroplasty of the trapezium, which is basically a hemiarthroplasty, it's a bit of silastic plastic, which is no longer used now in this country at least, and I think has been withdrawn. They found very good results. They stayed in, most of them, for 5 years and 10 years. And they found that 2 new implants, the Electra and Motec modern implants, had equivalent results at 5 years. So that sounded very promising. But then you come up against this from Denmark, a prospective study of 39 electroprostheses followed up for 4 years. And you'd have thought the registry would have got it right. And they reported a fast recovery, but very high revision rates, 44% at 72 months, which is completely in contradiction to the Norwegian study. So though compulsory arthroplasty registers are important, I think they have to be absolutely compulsory, and yet absolutely every single implant of every type needs to be entered into them. And to be fair, as you're studying the implant so carefully, maybe you should record all trapeziums as well, but except you can't take them out, so I suppose that wouldn't work. Silly question. And again, loosening of the trapezial component seems to be the main issue. And here's that surface one, which you can see has failed with loosening. People recently have been attacking my view that there isn't a good trapezio-metacarpal joint arthroplasty at the moment, and have reported this Maya arthroplasty, where a 6-year follow-up of 80 patients was published in 2017, and saying this is maybe the answer, this is the answer. That's what they're saying. It was a single center retrospective study of patients operated on between 2006 and 2009 with a minimum 5-year follow-up. The indication was good for surgery, pain, and no response to non-operative treatments. And for some reason, they only recruited 80 of the 116 cases. Maybe they didn't say, but maybe they just couldn't contact them. As is often the case, it's easier to contact and trace patients in the NHS than in other health services. Sorry. And of their 80 cases, at 5 years-ish, they had a 5 implant failure rate, 8.3% revision rate. That's not bad. 4 developed CRPS, whether it was true CRPS or pain of unknown origin, I don't know. And if you look, their visual analog scales, if 1 is the bottom line, were very good. You'd have thought 1.2, that sounds good. But if you look at it, the standard deviation of 1.8, which is larger than the mean, means that there must have been a significant tail of some high scores on the visual for pain, which means some were not totally painless by any means, and some were obviously quite painful. And again, if you look at the DASH scores, which is really a bit of a measurement of symptoms and of function, the mean follow-up was 17, but with a standard deviation of 16. And most of the DASH scores, I suspect, were clumped between 0 and 17, as that's what we had in the trapeziectomy study. But to get such a large standard deviation, it must mean that there's some patients still with high DASH scores out after surgery, which means poor function. So my interpretation of this is there are some clinical failures or not very good outcomes, just as there are for trapeziectomy. I ask you, should we change practice on the single retrospective, single center study where there is no comparator? Well, I don't think one should. The temptation is to do that. But what you've got to remember is there's a thing called publication bias. People are quite happy to present and report their good results, but they prefer to bury their unsatisfactory poor outcomes. So if there's several surgeons out there who with high failure rates and they can't get the operation to work, they may think it's their fault, it's something to do with them, when it is actually the arthroplasty, but they don't publish, so nobody knows. They tend, and in the NHS, it's easier to publish poor results because your practice isn't so affected as if you're if you work in a private health basis where you can lose your practice. I do believe there is a need for a compulsory register, just as there are for hip replacements, and I think the hip replacement one has done a lot of good, and that all TMC arthroplasty should be inserted. I think it'd be fair to say that you should put some trapeziectomies in as well, and that will give some comparison, but not a fair comparison of trapeziectomy with the trapeziometacarpal joint arthroplasties, as it wouldn't be randomized and there may be different patient selection criteria. If you are going to assess the outcome of trapeziectomy versus a trapeziometacarpal joint arthroplasty, I think first of all, you've got to have an implant which you've been shown has a satisfactory 10-year survival rate. You don't want to start a randomized controlled study and find by 5 years half the implants have failed. You need to know that you've got an implant which needs to stand the test of which stands the test of time. And what you're really seeing is if the implant, trapeziometacarpal implant, works clinically better than a trapeziectomy. And I think you'd have to measure 3 things: the patient's assessment of the long-term of function at long term, and that would really be a PROM rather than measurements of angles or strengths, a patient-reported outcome. And then you need to look at the short-term outcome. How long what did the patient have to go through to get a good result? And it's claimed trapeziometacarpal joint total arthroplasties have a quicker recovery than trapeziectomy, so it'd be important to look at that as well. And the thing everybody forgets, or used to forget to include, is the cost to the health purchaser. If you do a cost benefit, if you show the trapeziometacarpal joint arthroplasty appears a little bit better than a trapeziectomy, is it cost effective, and is it worth the health purchaser paying for the implant compared to carrying on with a trapeziectomy? And I do think that's quite important, particularly in an NHS and country strapped for cash at the moment. So I'm just going to finish by saying what I do now. I do a trapeziectomy. That's my standard operation. I don't do any arthroplasties. And I do a simple trapeziectomy, except in a young or heavy manual worker. I've stopped doing arthrodesis because I don't actually believe fusion. I don't believe it does produce a better thumb, a stronger thumb than a trapeziectomy. And the only reason I do an LRTI is I always have this sneaking suspicion, what if I'm wrong? And in young people, a trapeziectomy with LRTI does better than a simple trapeziectomy. So they get an LRTI. There's no proof that it's needed, but if you look at the average age of the patients in my studies, they were all in the average age was about 60, 62. And it may be that younger people with more demands on their thumbs would do better with a trapeziectomy with LRTI, though I saw no evidence to suggest that it may be the case. But in all my trapeziectomies, I don't do an LRTI, but I do so to something called a vicral rapide sling. And you'll notice it's vicral rapide, so it will be gone within 3 weeks, so it won't affect their long-term outcome. And that's because I always have a concern that the pseudarthrosis may sublux dorsally. It's never causing an adduction deformity, and I don't like that. And I don't like putting K-wires in to hold it in place, the pseudarthrosis in place while during the post-operative recovery, because patients totally hate K-wires. So instead, what I do, and it's a bit of a fiddle, is with a 3/0 vicral rapide, I suture around, through the APL, abductor pollicis longus tendon, and flexor carpi radialis tendon, 2 loops round, and then pull it together, but not so much that the 2 tendons are touching together, and tie it. And I hope that the FCR, the tension in that, will keep pulling the pseudarthrosis in and prevent subluxation or dislocation. It's a theoretical concern I'm treating because I haven't seen any dislocations, but I'm just paranoid, and I think it's best if you can hold the thumb firmly in place to begin with. It may be a total waste of space and not worth doing, but I'm not making any money out of it. I have no shares in Ethicon. And I should say that I still do trapeziectomies for that's all I do for patients with scaphotrapezial trapezoid arthritis. A lot of people worry, what about the scaphotrapezoid joint, which is arthritic as well? I just leave that untouched, and it seems to be okay. I've had 1 or 2 patients where I thought there may have been pain coming from that, but on the whole, I think there's no need to excise any of the scaphoid or the trapezoid there to try and get rid of that arthritis as well. And I suspect the trapeziectomy is a pretty powerful denervation of that whole area. Briefly, MCP hyperextension can occur. What should you do with that? I used to be concerned about it. But then the range of passive hyperextension, I think, is probably not critical. And some people can hyperextend their thumb MCP joints 70, 80 degrees. And you think, golly, I've got to do something about that. But when you ask them to make a pinch, the hyperextension isn't there. So when they're actively using the thumb, they can control the hyperextension and it isn't a problem. And if that's the case, I don't think the hyperextension needs to be addressed. If it is there and there is some collapse of the thumb when making a pinch with hyperextension, you can do an MCP joint capsulodesis. That is fiddly. And basically, through the front of the thumb metacarpophalangeal joint, you find the capsule, lift it off its insertion on the metacarpal neck, push it down a bit to advance it, to block hyperextension and fix it in place. Here I've used a bone anchor. I suspect many of them stretch out. It's unbelievably fiddly, and the sesamoid bones get in the way. You can also do a sesamoid metacarpal head fusion that has been described, which is unbelievably fiddly. And basically the idea is to fuse the sesamoid to the metacarpal head. So there's no way that the MCP joint can hyperextend, but it's difficult to get at, difficult to fuse. The head of the screw I put in here irritated the patient on the front of the thumb and had to be removed. So I'd recommend it's abandoned. MCP fusion, that's okay, can be done. It's quite a fiddle, and it's not a fiddle, but it's an extra operation for the patient. I do that sometimes, but if you just ignore it, it's very easy, and usually you'll be fine. And I tend to ignore most MCP hyperextension deformities now, unless they are gross and they're on pinch. So that's it. And I'll just conclude, new techniques come and go, but trapeziectomy, some form of it, in my opinion, for now remains the gold standard. That probably won't be the case forever. I suspect in due course an arthroplasty will be developed, which has a good lasting lifespan, doesn't loosen or cause problems, and provides good function. But the only way we're going to find that out is by carefully assessing new implants, rather than just going on finding reports of one person who's done them and they work very well. That's important information, but it doesn't show that they work in everybody's hands. So with basal thumb arthritis, I would just ask you one question. Gervis produced his paper in 1948. How far have we progressed since then? And I apologize, this slide is a little bit out of date. I think it should be 73 years now. Thank you.